biggest lesson that you learned about the whole process? Be something that you did that you were surprised about, part of the method of science that you used that was more effective than others. What do you think? How it went for you, and something that stood out?
They go up, but not that
to get it done. So a lot of times people will come to you in whatever job and you'll make the assumption that they're already pretty motivated because they've turned up at your doorstep or at your work site. But that might not be the case. They might have been kind of cajoled to come, the doctors told them, or their moms made them come and try out for the team, or they think they should be there but they're not super motivated. So figuring that motivation out will help you understand where they're at and maybe try and help you figure out ways to help motivate them a little bit more. Good. What else? Somebody from the middle. Middle towards the back. If you want to point at someone back there, Brad, encourage somebody. Who you want to pick?
What about you?
What was the question? What did you learn from doing your project?
That it's easier to stay focused when
of staying organized, some form of planning or tracking method, whatever works for you can really help you out. But if it's not there, if you haven't got that organized, then things can drop off in the first week or two, and then that's when people quit, right? Okay, over here. Yep.
Feeling of failure.
Okay, explain a bit more.
Definitely I didn't end up changing my behavior, but knowing that I can keep going on with it after this project. But every week there was like 2 or 3 weeks where I didn't actually make my goals. So I had to review them or try to do goals the next week.
Okay, good. So dealing with failure, and then be careful with that self-talk. Is it failure if you just didn't meet your goal one week, but you still made strides and you were aware of your behavior and you still learned something? I would say it's not necessarily failure. So be careful with the self-talk with that. But that's behavior change. Did anybody go up in a linear progression? They increased big chunks every single week. They didn't have a week where it dropped. Maybe a couple of people, but most people, life isn't like that at all. We plan a lot of things linear, right? We say we're going to go and come in school, we're going to finish here, or we're going to start training for this, and then we're going to be up here physically, or I'm going to start here, and I'm going to ace this test. But life is more like this. So to be okay with the days or the weeks where it doesn't work well, or you're sick, or you need to take time off, and be able to not quit at that point, or beat yourself up about it, and then move forward to keep making changes. Come back, reassess your goals, bring them down a little bit, and then move forward. And that is really key to helping other people too, when you're working out, when you go off and graduate, is to figure out where they're at each week, keep getting them to work towards their goals, but understand that things can plateau at times, or things can drop off for a week or two, and that's okay. You just learn and continue on. And now 6 weeks is just enough time to get you aware of what's going on, what you're doing. And for some of you, it's just starting to make that habit forming. So some of you have just started to do your behavior without thinking about it too much more. Without having to put it in your planner and be aware of it, you're just starting to do it. Usually it takes about 6 months to make it completely habitual that you'll carry on with. So it's up to you at this point whether you continue on with it in some way, shape or form, or completely quit. But you'll be able to use the skills, hopefully, that you've learned through the process to move forward. So it's going to take us a couple of weeks to get through all the papers. We'll be grading using the rubrics that is posted up, and you should see that as soon as we put the grades in. We'll probably put some comments on your papers too, and you'll get them back slowly over the next couple of weeks. So the last major paper is the event participation. So make sure that you've got something on your agenda to do, because it's due in a few weeks. So make sure you find an event to go and attend if you've not done so already. And as soon as you've done the paper, you can start handing it in into your group folders, so you don't have to wait for the deadline for that. Okay, so that is all that I have this morning. And this morning we've got these 4 lovely folks who are going to come in and talk to us about functional movement screen and teach you all about those joints. And I will let them introduce themselves. So whenever you're ready, this pointer works here.
Okay. Good morning.
Morning.
Let's give a round of applause, please.
They know us, so it's safer to give us a round of applause before we start, and then that way we've gotten one in case everything goes really bad. And then you don't feel obliged to clap at the end because you already did it. So I'm Alan Nisipny. I work in the athletic training programs here on campus. We have 2 AT programs right now, the Doctor of Athletic Training and the Master of Science in Athletic Training. And so most of you are aware of that. We have Dr. Jamie Baker, who's an athletic trainer and a physical therapist, or a physical terrorist, as most of our patients used to call him. And Rusty Baker, who's an athletic trainer, and he was our first Doctor of Athletic Training graduate, so not too shabby.
Like another round of applause.
And then the brains behind the operation, Jairus, who's almost 12 weeks, so he'll be sleeping through the night next week. So that'll be awesome, won't it? So when I went through school, I think I went through school. It's hard to tell. I kind of paged myself. So like a lot of you in the room. Maybe even more like some of you that aren't in the room. But when I went through school, I learned a lot about the body but didn't learn a lot about treating patients or treating people who happen to inhabit bodies. And so it's a little tricky to just treat the physical being. And so as I learned more about treating people, then I started thinking about, well, that's interesting because there's this other component that we never really learned about that was wellness. That's kind of odd in a healthcare profession that you don't learn a lot about wellness. You learn a lot about fitness, and you learn a lot about normal physiology and normal mechanics and normal lots of things, but you don't learn about wellness as a pie very often. So that's one of the things I'm really excited for you guys about, is that you get a little bit more holistic view of the potentiality, I don't know if that's a word, but it seems like a good word, of what you can do. And so that's pretty interesting. So one of the things that we were talking about last year that we'd be really remiss if we didn't talk about in a class like this, when we're talking about, we're introducing you to some measures, we're introducing you to concepts like stretching, or to maybe some basic nutrition ideas, some basic wellness ideas. There's a whole idea about functional movement. And so, how many of you want to work with clients or athletes to help them improve their performance in some way? Whether they're going to be, athletes or somebody that just wants to get in better shape. So, and then, how many of you who didn't raise your hand want to work with patients? Okay, so we've hit the majority of people in the room. Did you feel that? It's a very subtle hit, but we hit it. Not very funny. But at least I'm dry, so it's very helpful, like in the rain. So when we talk about the function of, it's not a very useful task from like June to October here, but after that, game's on. So one of the things that we really need to focus on is, in order to help somebody with their peak performance, we should be able to ensure that they can walk safely, and that they have the basic foundational movement that is the basis for all function. Does that make sense? So if you don't breathe well, then you breathe, let's say you breathe 15 times a minute, times 60 minutes in an hour. It's a lot. It's like 900 times, something like that. Times 24 hours. That's a lot of incorrect breathing. And if breathing is the crux of our being, then everything we do after that, we're compensating for the fact that we don't breathe well. So we're already starting with compensation. The next thing that we think about is, can your body move freely and coordinatedly? It's an adverb, right? So we can throw an ly on there most of the time to be safe. A little English lesson for you. Coordinatedly. Be a good Scrabble word too. So, in order for us to be able to do that, we need to be able to just break down the basis of all of our function. And so there's a group of people who, Gray Cook. How many of you have ever heard of Gray Cook? Okay, get ready to live. Pretty exciting stuff. They came up with something called the functional movement systems. And Gray's been around for a while, and he's been doing really good things in the world of fitness, performance. He's a physical therapist, but he also is a strength and conditioning guy. But anyway, he came up with this basic criteria of establishing whether somebody can move properly or not. And they've also correlated that with predicting injury. So there's a certain score, this is a test, that is a basic movement competency test. And most of it's static, and most of it's just testing your ability to do things while you're not moving, because it's a lot more complicated to do that. Once you pass that and you're doing good with that, then we can start to break down sport-specific movements or functional movements after that. And so, or higher level functional movement. So anyway, they came up with this thing called the functional movement screen, and they've actually shown it to be very predictive of who gets hurt and who doesn't get hurt. It's interesting because the whole basis, the whole reason they came up with this is do you know what the #1 predictor of injury is? What's that? Heard it somewhere.
Incorrect form.
Kind of.
Walking.
Previous injury. The #1 predictor of injury is previous injury. Why? Because we generally don't fix it all the way, and we make compensations, and those compensations lead to other compensations, lead to other compensations. You get to the end, and you don't even know how you started walking like this. Like, how long have you been walking like this? What do you mean walking like this? I have no idea how you even walk like that. But your friends can see you. How many of you have noticed somebody from more than 100 yards down the street just by the way they walk? At dusk. Pretty obvious, right? And we're repeating that movement pattern over and over and over and over again. And so it's a very consistent thing. Now, if we have competencies or compensation in that, then we can see how now we're repeating, grooving those compensations.
Give them an example.
Sure.
Who in here can't touch their toes?
Exactly where we were going with that.
Your closest hub of
Oh,
here.
God.
How many times do you guys bend over in a day? A lot.
Okay.
Doctor said.
Yeah. Okay. So, so let's see what you got. Yeah.
I really can't get close.
Oh, okay, great.
That's not that bad.
No, that's pretty good. Okay, so go ahead and scoot forward a little bit. Back up. Yeah, perfect. That was a lot better. You were a little bit there.
Sorry.
It's all relative, isn't it?
Yeah.
Okay. So what I'm going to do is I'm going to have you close your eyes, and then I'm going to put a little bit of pressure on you. And what I want you to do is not make me push you back. Okay? So don't let me push you back. And as soon as you feel my pressure, I want you to bend forward. Okay? So close your eyes. I'm going to put my hand right here. Is that okay?
Yeah.
Okay? And don't let me push you back. Now touch your toes. Okay? Let's do it one more time.
Oh, hold on. I was not ready.
Sorry. Get ready. Okay, do it again. We might as well groove it. What the heck, right? We got ATM spitting out $20 bills. I'm stopped. We start spitting out pennies. Like 1 an hour, and then we start stopping. Let's do it. Let's do it one more time. Okay? What does this mean? Well, it means that she was all messed up. And that she was using an extension stabilizing pattern for a flexion activity. Do one more.
Okay, we said two.
I know. I can't. Okay. Now go ahead and touch your toes.
Oh, okay.
Yeah. Okay, good. Now what I want you to do, closer or not? A little bit, right? Half the distance to the goal, right? Now what I want you to do is I want you to pretend I'm pushing you back. Don't let me push you back. Just do it in your mind. Close your eyes, pretend I'm pushing you back, and then bend forward and touch your toes.
I'm kind of rocking with it, though.
Okay, do it one more time. Do more country.
Okay.
It's hard to tell these days, right? Like the new country is the old rock. I don't know. Is that pretty good?
Yeah.
Okay, good. Okay, so let's do one more, just to make sure that's not a fluke. Okay, who else wants to touch your toes? Nobody else wants to touch your toes? All right, come on up. Do one more. Now, it's possible that they just can't touch their toes because something's locked or something's tight, but very rarely. Okay, so let's see. It's your world.
Okay.
Okay. No, that's okay. You just forgot. Now go. One more person. Who's not very flexible. Somebody's got to be not very flexible. Can you touch your toes?
Sometimes.
Sometimes.
This guy can't touch his toes.
Who can? All right, come on up. This will be a true test. Are you like ultra inflexible?
Okay.
Okay, yeah. Feet together. Let's do feet together. It makes it harder.
All right.
Yeah. Awesome. Okay, go ahead and stand up.
Okay.
Now, don't let me push you back.
Okay.
Okay, now bend forward and touch your toes.
Hold on. I'm letting you push me back.
Okay.
Yeah, that's definitely easy.
Yeah, a lot easier. Well, it's helpful if you're not using your back muscles.
Right.
What's happening is we're taking the brakes off. We're saying, okay, use your belly muscles, your deep belly muscles, to stabilize going forward, not your back muscles.
If you think about it like this, as he's going
Do
down,
5
it's
more.
like your extensors are letting the rope down.
Yeah.
Versus just letting your abs go. Yeah, I'm supposed to do this. This is a normal motion. I've done it since I came out of my mom's womb, and it's not that big a deal.
Okay, good. Now bend forward and touch your toes. Did you guys see that? He's just old. That's what he said, right? I can't touch my toes, I'm just old. But I made him younger. If I were you. Awesome. So, isn't that cool? So, how long would that have taken? He gained, I don't know, 8 inches, 10 inches? How long would it take to gain 8 to 10 inches from stretching? The rest of this lifetime. That's if you're really diligent and you do it with the best of what we have. You know, our 12-week stretching programs might gain half an inch, 3/4 of an inch. That's with, 15 or 20 minutes a day. Most of the time it's not about what we usually think of as tightness. It's usually about improper movement patterns. Sometimes it is about something being stuck or a muscle being tight. It's either improper movement patterns or something being misaligned or stuck 95% of the time, in my opinion. Maybe 5% of the time a muscle's actually tight, and it's usually after you've strained it, and sometimes we actually have to loosen it up. But very, 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 very rarely is that the case.
To give you guys an idea, part of my dissertation was actually studying this. Because I worked in an athletic population thinking, I got patients, my athletes who have tight hamstrings like crazy. I work around track, I'll do all kinds of techniques that are faster in stretching. And we learned this process through my doctoral program. I went 4.5 months without getting one patient that needed to be stretched. That I fixed their inability to touch their toes, either with this technique that he just demonstrated or one other technique, in 1 to 2 visits every time. Do you know what that did to my philosophy of patient care? Because for 10 years I was taught muscles were tight and we stretch those things, and by golly it works. And to have your entire philosophy implode on itself in a day can make patient care very painful at times.
Especially the history of all the people that you didn't get better. Oh, if I only knew. Okay. So I'm still waiting for my time machine so I can go back and fix a couple of those things. So what this is going to do, this functional movement screen, is it's going to basically give you an overall score of their basic functional movement competencies. And then from that, you'll be able to tell their injury risk, potentially. And then we'll also be able to highlight certain areas that are or are not moving well. Okay, so let me start. Assessing movement. Now you guys will learn through the program and a little bit in this class, and then if you're in exercise science and you get to 493, which is exercise something in prescription, assessment and prescription or something? Testing and prescription, that's right. I knew that wasn't right. What do you know? Okay. You'll learn stuff like this, but you won't learn the magic that what you're seeing probably isn't what you've been led to believe. Because most people don't know this information. Most people don't know that you can change something like that. It's closer to the click your heels 3 times and wish it to be true. It's closer to that than the things that we've been teaching for the last 20 or 30 or 100 years. Okay, so these are certain things we can do. Rusty's going to take you through the actual screening process and some of the background of this.
So, real quick, that looks pretty normal, equal from person to person, doesn't it? You guys had a client or a patient do that and you saw those side to side, you guys aren't that far apart. And that's often how we would assess movement, passively, in a way that is not functional. Now, Gray talks about this. We all like to use the term functional. What does it mean? And nobody can agree on function. The APTA, the American Physical Therapy Association, asked for a definition in the mid-90s, and we still don't have an agreed upon definition. So their idea was, well, if we can't agree on function, let's go ahead and define dysfunction, which seems easier. But then they came up with what I think is a lame definition, the absence of function. Thank you. Now what are we going to do about that? So we see this, and if you're a traditional clinician, you think this is normal. But then you ask them to do something functional, and they can't do it. That's the same motion. You're going into hip flexion, flexing your knees, your ankles are going into dorsiflexion. What changed the minute we actually asked you to do it? This is what we want. And one of the things I like about Gray's seminar is he actually talks about, I forget if it was World War I or World War II, where they were teaching a shooting position where the military men would go all the way down into a duck squat, feet out, and they would shoot for hours in that position.
That was the sniper position or the basic shooting stance that's been modified.
Which makes sense because if I'm getting shot at, I want to be as small as possible. I don't want to be a big target. They stopped doing that because they found out that people that came in the military could no longer do that basic movement. Which is funny because everybody likes to talk about athletes today are bigger, faster, stronger, better, but they can't move. And so when we ask them to do this, this is what we want. We want a position where when they look at this, they actually get their butt past parallel. That's normal, that's healthy. He's not, if you look at his head, the head's basically aligned with the knees. He's not way out in front. His arms are over top of his head. His feet are actually flat on the floor and they don't externally rotate. That's normal motion. Every one of us should be able to do that. The whole comment of, I got old. You didn't get old. You stopped moving. And we had no idea of how to assess this, and so we ran into these problems of how do we pick up on this. And that's where they came up with the FMS system. Or I should say the functional movement screen is part of the system. The system is an entire, all-encompassing system that looks at movement, both when somebody has pain and when somebody doesn't have pain. If somebody does not have pain when they move, they go into the FMS, which is the functional movement screen. If somebody has pain, they automatically get a 0 and they have to go into the SFMA, which is the selective functional movement system. If somebody has pain before they, I like to bash CrossFit, so if you're a CrossFitter, I'm sorry, I apologize in advance. I thank whoever created CrossFit. You know why? Because it means my wife always has patients at the PT clinic and she has a job forever. And it's not because CrossFit is bad. CrossFit is actually really, really good. If you look at PE classes in 1920s, guess what they were doing? CrossFit. That's what it is. But CrossFit is really, really bad because people can't move anymore, and you don't assess people before you throw them into CrossFit. And so you ask people to do movements and exercises they can't do, and they get injured because of it. That's why CrossFit has the highest amount of rhabdomyolysis of all fitness programs, by far. They don't assess people. You have a bunch of untrained people making people do movements. So Gray Cook and his group said, we're going to fix that. We're going to create a screen that allows fitness professionals, who maybe aren't medical professionals, to screen their clients and assess who's at risk of injury. And then we're going to create a system that allows healthcare professionals that are medical professionals to communicate with our fitness professionals so we're all speaking the same language.
What's rhabdomyolysis?
You can explain it in a sentence.
So basically think of massive muscle cell breakdown, where your cells basically are dying off and your body can't handle the waste products, so your kidneys shut down. It can actually kill you.
It's been a lot more common in the last, well, I don't know if it's been more diagnosed or more common, but you know, you've seen all these things like P90X and CrossFit and T25 and D84 and U29 and HMS 54. Lots of things where people are really, really training hard. And you know, high intensity training is shown to be very effective. But we also probably need to figure out whether people can handle that first.
You see it occasionally in athletic teams, but very rarely. It's almost always in fitness programs because they're just not ready for that. Because one of the things that would happen is if my better half here rehabs an ACL and the insurance company says they're paying for their rehab, they're cleared. What's their term they like to use? Cleared for activities of daily living. I'm an athlete. My activities of daily living mean I need to run a 4.4. Yeah, right. I need to have 40-inch vertical. I wish. But my athletes might actually have to do those things, and they can't move. So how can I give them back to their strength coach so their strength coach knows what they can or can't do, and the strength coach knows what kind of training they need to do to get back to the athlete they were before? And that's where the FMS came in. How can we transition people from rehab to performance, and how can we prevent injury by identifying people who can't move in advance? This is not a diagnostic tool. This is not going to tell you that you have a torn ACL. This is not going to tell you that you have Achilles tendinopathy. This is not going to tell you that you have erector spinae problems. This is simply saying you can't move. And we're either going to use the screen to tell you what movements you need to do to correct your movement dysfunction, or we're going to say you have pain doing these motions and you need to go see a medical professional. That's what the screen is for, to quickly identify people. And the beauty of this is once you guys start to do this, you can probably get through a screen in less than 4 or 5 minutes and do it well. Do it well. What did he design it around? They want to be able to grade quality of movement. That's one of the things, I don't know how many of you guys feel this way, but I felt this way through my bachelor's programs and my master's programs. You take a biomechanics course, but how many of you feel qualified to say, wow, that person moves really, really well? What is normal movement? One of the most painful experiences for me the last 13 weeks that my son has been alive is I looked at him and I'm like, is that normal? I don't know. He looks a lot at lights. Is the TV bad for him? Should we turn the TV off? I don't know. But he's quiet with the TV on. What am I supposed to do? I have no idea. I felt that way a lot of times with my patients. Well, that squat looks better than his, but how good is that really? What's the squat supposed to look like? And when is it a problem? When do I fix it? How can I have one athlete who has really tight hamstrings and they never have a hamstring problem, and another one who has hamstrings that aren't quite as tight that is having problems all the time? And so that's kind of what we're looking at here. We want it to be body relative, meaning it fits each individual person. It's not you have to be the greatest athlete on the planet to go through it. We want it to be time and space efficient. You can see what Dr. Sidney's putting together. That doesn't take up a lot of space in your gym. It doesn't take up a lot of space in your clinic. You can put it away and then take it back out. Maybe not. They talk about minimal expense. That's plastic PVC, and I think that's like $400. How many of you guys? I don't want to be sexist, but I'll pick on the guys. Guys, how many of you are good with a set of tools? How many of you think you can build that for less than $400? So you don't have to buy what they sell. We bought it because we wanted you guys to see it and be able to practice with it. They're in the cage in the PEV building, Alan?
They will be. Yes.
So that you can see it, and then you can be like, oh, I see exactly how they built this. I can build this myself better. And we wanted it to create, they wanted, I don't want to say we, I didn't have anything to do with it. They wanted everybody to speak the same language so they could put the results in a database and we could pull results from it. How do we know what score is bad if we don't have 1,000 scores? And then how do we know if that 1,000 scores translates to everybody if we don't have 10,000 scores? So if this is reliable, meaning that each of you can do it and end up at the same place and everybody can put their data into a system, we can start saying that football players who score below a 16 are at a high risk of injury. And firemen who score below a 14 are at a high risk of injury. And we start to know. And we can break down what movement patterns that they struggle in as we go through it. We won't go through all this stuff. You guys gave them this, right? So they can read it. So we'll save this. You do have to be able to remember your anatomy. Come up with a few key landmarks. The most common is the tibial tuberosity, the joint line of the knee are big ones, the distal wrist crease, the malleoli, and the ASIs. Because you're looking as somebody moves for symmetry. If I move and I shift, you want to see that my ASIs are now tilted.
So the ASI sounds like a bad word,
I assume they all have
but
that.
it's not. No, not yet. Yep. So if we look at the hip bones, that very prominent front of the hip bone, that's your ASIS. Okay? So the very prominent front of the hip bone, this is your iliac crest. That's not something up there, but this is your hip bone. You move forward, the very prominent front of the hip bone is ASIS. The tibial tuberosity, if you go underneath your kneecap and you feel the ridge of your big shin bone, right? That ridge, right where that ridge starts, that little divot there is your tibial tuberosity. Okay? Lateral medial malleolus, your lateral malleolus, a big ankle bump on the outside. Medial malleolus, big ankle bump on the inside. Distal wrist crease, and so if we look at the creases of the wrist, that's pretty easy to see. So just bend your wrist and you'll see where it bends, and that's your distal wrist crease. And then the joint line of the knee. The joint line of the knee is easiest to feel when the knee's bent. So where are the bones separate? It's easier to feel on the inside or the outside, actually. If you put your fingers there and you start to move, you'll feel where those bones are separated, where there's a little bit of space. That's your knee joint line. So they're really easy to do. But anyway, we'll talk about those and reference those, and we'll point them out as we're doing them. But pretty easy.
If I skip stuff and you're like, I don't know what he's talking about, just Baker, dude. Slow down, tell us what that is. I make bad assumptions. So, one of the things that you have to remember when you do this is you're watching the person. And so the best way to get good at something is to do it over and over and over again. There's the fun saying of perfect practice makes perfect performance. And I get that, but you have to start somewhere. So you have to start watching people move and start assessing it and go from there. And you have to understand that you're going to look from different places. If I want to watch somebody squat, I need to look at them from the front, I need to look at them from the side, and I need to look at them from behind. So that means minimal, how many times are they going to have to squat? 3 times. And as you begin doing this, it may be more. You may have them do it 2 in each direction. All right, I want to see you squat twice from the front. Now let me move to the side. Let me see you squat 2 more times. There's one key here, though. You do not want to coach them. You want to see how they naturally move. So if they don't go down the correct way, and you're like, hey, don't let your feet go out. You've now coached them. You've changed their movement pattern. You want to see how they naturally move without coaching. So the saying that Gray Cook then like to use is monkey see, monkey do. So one of the easiest ways to do this is for you just go, okay, hands up real high, feet shoulder width apart, squat like this, and you demonstrate it, and then they do it. And you make sure you do it, you finish, you watch them do it, then you move to the side. And once you've demonstrated it once, you just do your other views, because you don't want to change the way they move. Because if I walk around and say, I'm going to look at every one of you as you sit here, your posture, I'm going to evaluate your posture, what is every one of you going to do? Oh, look, I got great posture. Perfect. I didn't sit like this for the last 45 minutes of your lecture. So we want to be aware of that. You also want to consider distance as well when you observe people. So usually what they say is take enough of a step back away from your client so that you can see their whole body, and that I'm not doing my movement screen like this. Because I can't really assess how you look as you move when I'm in your face. Plus it's kind of weird. Like that whole personal space thing, why do you gotta talk 4 inches from my face? I don't like that, but it's that bad.
And so one of the things that you might do is you might zoom in and zoom out as you're doing it, but you'll still do it from a distance. So you could take in the whole room, right? But if you want to focus on something, you might be able to focus on one person in the room. And so you can naturally zoom in, zoom out with your vision. It's just what's your thing of focus. And so you might change what you're focusing on. The good news is, once they do one thing that's not good, they go to a 2. If they do multiple things it tends to bring them to a 1. If they do it perfectly, it's a 3. So it just drops you down every time. So you don't have to say, they did this, 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 and this. You don't have to write all those down. You just have to say, was it perfect, was it okay, or was it poor?
Or did they have pain?
Or did they have pain, which would be 0. But we'll talk about that.
The other thing in that area is, and this is the fun part, if they do it twice, I may look at a gross movement and say that's a 2, and I saw that your biggest weakness area was your ankle, so do it again. And like you said, I'll zoom in and look at what their ankle and their foot do during the second movement. Another recommendation, if we were screening people, I wouldn't want you to stand here. Anyone want to guess why? How cluttered is this behind me? Really cluttered. We generally want something where you don't have a cluttered background. So if they could stand in front of a white wall, it allows you to have contrast and pick up on their movement better, and it allows for them not to be distracted, which is always helpful as we go through this. More stuff that we basically already talked about.
So a lot of them have lots of words on there. We just put them on there so that you can have some reference. You can go visit the website, but those are just kind of read on your own stuff. Really interesting, but not something that we're going to
He
discuss.
basically covered it. It's scoring tips. And so 0 means they have pain, 3 is perfect movement, and 2 and 1 is not perfect movement without pain. You just have to differentiate. We'll talk about it in a second. So they came up with 7 tests. The deep squat movement pattern, which we've kind of already talked about, the hurdle step movement pattern, inline lunge, shoulder mobility, active straight leg raise, trunk stability, and then rotary stability. We'll go through each one of these in a second. Okay. Do not stop just because one of these is bad. And don't say, oh, your trunk stability is terrible, I did that one first. You screen the whole screen. So you don't just say one movement is bad, we're done. You look at it and grade it when the whole thing is done versus taking it apart in individual pieces. So deep squat, our movement keys. Torso is parallel with the tibia, femur is below horizontal, knees are over feet, dowel is overhead. What does a perfect score look like? This. Femurs broke parallel, meaning more than 90 degrees of knee flexion. Dowel's over top of the head. Back is in line. He's not leaning over his chest, or his head's not out in front of his feet. His heels are on the ground. The toes are pointed straight ahead. How many of you think you could do that right now?
Okay, 1 million imaginary points to the first 5 people to come up. I think that they might be able to do it. We got any athletes in here? Yeah, all right, we got one.
Oh, somebody has their bag out.
That is 5. This is 5 to start with.
So we've got 2 from this side of the room. So come on, 2 from the middle, 1 from over there,
Yeah.
1 from over there,
Okay,
2
good.
from the middle, 1 from towards the front, 1 towards the back.
Real quick question before we move. So we saw no hands raised that could do this. How many of you go to the gym? How many of you squat? So you're doing an exercise you can't do without weight? See the flaw in our healthcare system?
So how much of this is related to strength as opposed to functional movement? So can somebody who's weak not be able to do this, but they're actually abnormal movement patterns, just they're not strong enough to do that?
Well, the answer is you probably never know, but maybe less in my practice, even with 89-year-olds, 90-year-olds, maybe less than 2% can't do it because, I mean, the reality is somebody too weak to squat? Well, what's funny is once we fix their movement patterns, then all of a sudden they're strong enough to squat. They're just too weak to do everything incorrectly. And so when you're young, you're master compensators. And it sounds really bad, but it's not really bad. But as you get older, then every year you run out of compensations. And then you have the appearance of being really weak. But just like I was working with Dr. Vela the other day, and we're testing the ability to hold the arm up against resistance. And she got really tired really easy, like 2 fingers, whoop, right? Is that true? But you can't be that weak. You can't be. If we could if we just get you to recruit properly, your core stabilizers, and give you a good anchor with your scapula, then all of a sudden you can hold 30 or 40 pounds on there. Those muscles aren't that weak. It's the fact that they're working without a safety net, that they're weak before they start. And so if we can recruit properly, and we can show you different examples of that, then
The easiest example is we've taken, I say we've been more doctors sitting, excuse me, people with diagnosed rotator cuff tears.
full thickness tears, which means more than half of the tendon torn.
Torn. You ask them to do this, and their arm does this. Weakness problem. Recruit the shoulder, and all of a sudden you can't push their arm down anymore. The tear didn't fix itself, but all of a sudden the rest of the muscles that are supposed to be doing something have turned back on and are doing their job. We're efficient now. Right. Give it to the person on our right first. Person on the right.
Yeah, we'll just do here. There's more space.
Just thought that.
Okay, so monkey see, monkey do. So Jamie's going to show you.
I'm gonna show what?
Yeah, you're going to show monkey see, monkey do.
I'm gonna squat.
Yeah.
Alright. So with this, holding it above the head, right? Feet, shoulder width apart, everything in line is what you want to think. So this is what you guys are thinking as you're watching it. I wouldn't be telling her this. So you're coming up like this, you squat all the way down, and then come back.
And you go hands maybe just a little bit wider. Narrower is harder, but wider. If you think about the shape of the lats, the Y, that's probably pretty good. And that was pretty good. She came forward a little bit, but that's pretty good. You don't see that very often. Yeah.
Those love pops.
Let's do that one more time.
Guys, you guys are in the front, you're going to have to share what just occurred.
Okay. Yeah.
So, is she a 3? What did you guys in the front row see that jumped out at you? What did her knees do?
They went in, but she's come back up.
The knees collapsed together. What did her feet and ankles do? Out. Do you know what that is a major predictor of? ACL tears.
Yeah, like ACL, like I see that, and I think if that happened quicker on the court, that's a perfect mechanism for
By the
ACL.
way, you didn't hear that.
But that's easily fixable. And that's where we start talking about prevention.
So if I was going to do this, I'd say feet shoulder width apart, arms up over your head, out a little bit wider than your shoulders to where you're comfortable. Go ahead and squat down. That's pretty good. Now, this is why we do views. From the side, you watched his hands come forward a little bit. And from the front view, you couldn't see this. Go ahead and turn sideways and do it for them. And don't fix it now that I set it up.
I'll try not to.
But still pretty good movement pattern. A lot different. Would you hop up real quick and do one for the side so they can compare? Now we know that you're a bit different. How about her side view? They look pretty good to you guys? I couldn't see it from here. So you see how potentially why it's important to see from multiple views?
Now you did see an athlete though. All of a sudden we cued her a little bit and she changed like that. But the problem is that that's a cognitive change and that won't rewrite itself. That it actually has to be reactive in order for it to stay permanently. But it just shows the difference between an athlete and a non-athlete.
What we see in the front?
Look pretty good.
Did we see her feet do this again? So same thing. That's why you look at the view. She can't be a 3.
That was an excellent 2. Now 2, in this system, 2s aren't bad. 2s are kind of average. There's something to work on there, but it's probably not where you would start. Most people will have a 1 or a 0, and then that would be where you start. 2s aren't bad. If you have 2s all the way through, you'll still be okay with your scoring.
You're right on the cutoff.
Yeah. Yeah, but you're still okay. If you start mixing in 1s in there, or they're all 2s, then you're gonna have some, you're at an increased risk. But a couple 2s, not bad.
Off balance on her feet there. Rock back. But pretty good movement as well. So I would call that a 2 as well. So very quick movement that we go through. This is perfect. Most people don't have perfect. If you are unsure, guess what you score? 2. Score low. It's better to be safe than sorry.
Or if you're unsure between a 2 and a 1, then it's a 1. Now the other thing to think about is what we didn't ask is, did any of those 5 have any pain with that? Okay, 0, 0.
Then you'd ask, where was your pain, and describe it so that you can tell that to the medical professional so that they know. This is what she did, this is what she felt, this is how she rated it.
Yeah, and so that would be a referral to a medical professional. Once that's cleared, then potentially they could come back to a fitness wellness professional. And all it means is that you're not going to start treating people that have pain because it's too complicated. That's why people go to school to learn how to do that. So you go to school to learn how to treat healthy people that can be more healthy, or people that want to be more well but they're not having pain or other risk factors.
So one thing we would change for the people that scored a 2 is we would now put the hurdle underneath their heels.
Okay, same 5 came up. Nobody got a 3, right? Okay, go to the 2 that had pain. They're done.
Where'd they go?
Yeah, same 3.
Yeah.
Oh, we only have 4?
Yeah.
Stand face your class, but put your heels up on the board.
That'd be nice. So you want me to do it
If it's
again?
not backwards.
What happened to our movement there? That was pretty close to perfect.
Do it one more time. Let's see if it was a fluke. Very good. She got the parallel. No, she's in jeans, right? So that could be jean, she didn't quite break parallel, but that could be jeans. Did you feel like you were getting tight on it going down?
A little.
Just a little bit, yeah. So once they start giving her a different input, her body's going to be like, I'm going to try not to just split my pants. So the body will change. That's how quick it changes. Because nobody wants to walk around with pants that are split.
Get out of the way.
Look at that. He actually started worse than he finished. Go ahead, put your arms back all the way to start with. He actually got into a perfect position as he went down. That is 100% perfect, at least from the side.
So that's how you confirm a 2. If you can lift their heels up off the ground and it fixes their squat, it tells you there's a 2, and then you kind of know what we're... You have to go into the breakouts for the system, which is why you actually have to buy the book and take the course. But
So what did we change there? Just out of curiosity. What's that? Okay, you shifted the center of gravity forward. If you talk to any healthcare professionals, what would they have said?
Or what? Then
What did we change?
basically you're getting rid of dorsiflexion
Yeah,
of
so
the ankle. So the position of the ankle, right? Dorsiflexion is bringing your toes up. So a lot of people have difficulty getting in that position. So by elevating the heels, you're decreasing the amount of dorsiflexion they need to get into that lower position.
and there's a good chance that you guys were right and that all the healthcare professionals probably weren't right. In fact, you'd probably be right more often than the healthcare professionals with that. Because what we can do is, based on that theory, we can actually test how the ankle joints move under loading. And if they can move perfectly there while they're not stabilizing, then that tells you that it's not the ankle joint. That it was just the fact that you shifted your gravity, center of gravity forward. But very interesting, you can tell all that.
So can people do that with weight? So if someone's squatting and their form's not that great, they just put something behind their heels?
That's a crutch, right? But if you have to squat, then squat right,
Yeah.
right? But maybe over the course of, maybe you work on that on the side, right? So you guys working with strength coaches, or you're working on teams or something like that, they're not going to say, why don't you stop squatting until you get your form right? They should, probably, in my opinion, but it's not going to happen in this world. It's probably not going to happen. And so, if you guys get a chance to make that choice, maybe you would do that. But in that case, you could do that. You could also lower that by 1 millimeter or 2 millimeters every week. And eventually they would start to learn how to do it. If you do it too much at once, they don't have a frame of reference for that.
Is that what weightlifting shoes are for? I know that rowers always use them. They have a thicker
It'd be cool if you can, if the back of the heel opened up and you could take a millimeter out at a time. That would be really cool. Invention. Anybody wants to do that, I'll let you have it. You can patent it yourself. It's not Dragon's Den. I don't have any money to give you, but that could be good. Yep.
This would be a 1. They can't squat down all the way. They, even with the board underneath their heel. And I promise you, you will see athletes who look good on a soccer field who can't do this. And this needs to be fixed. So that's deep squat. The next one is a hurdle step. With the hurdle step, we're looking more at a sagittal plane, which means in front of them, they're moving through their entire system, looking at hips, knees, and ankles, their spine not moving, and then the dowel and hurdle remaining parallel.
Let's get one volunteer. Doesn't matter whether you think you can do it or not. Just come on down. Let's make these quick. Let's do one volunteer. Now that you've seen one done.
Front row, you win.
Yeah, whatever.
All right.
That's what I saw you flinch. That was the problem.
And so what's cool about this system is it's graded to the person. So
Up over on your shoulders.
wait, before we do that, we need to measure the height of the.
Oh yeah.
And so what we do here is this is what this is really handy for. You don't need one of these, but it's really handy. That if we feel like the tibial tuberosity, wherever the heck that is, we're looking at about 19 inches. So if we put that right here, it goes 19 inches. You could just have them stand up next to it and raise it that way, but it's really easy to just hold that and then you can do it one-handed. Okay. Oh, sorry. Take your.
So over your sit down. What you want to do is lift your knee up as high as you can, balance on one foot, step over, touch your heel, and then bring it back over. Just touch your heel down, and then bring it back to it one more time.
Here we go.
Something cool about this test, you have the athlete do it in the shoes that they use. So if they wear cleats, have them do it in the cleats, but have them do it on the surface that they work on. If it's a basketball player or a tennis player, have them use their tennis shoes. On the SFMA, the other test, we do barefoot. But this test, we have them try to use shoes that they would do. If they wear cleats, but you can have them wear the shoes that they train in indoors, because a lot of people will train indoors too. You can have them wear those.
So part of the reason this score wasn't perfect is because of the shoes he's wearing. And that's the big thing. But what we want is basically they can put their toes against this board and they can lift their legs straight up. See, I'm not tall enough. Been storing my whole life. They can lift their legs straight up over the cord, touch their heel, bring it back without touching the cord itself. And if you think about it, that's not that big a deal to be able to lift your leg up to that position.
I'll show you the most common error, and I don't have to try to show you this error. I'm just naturally able to do it. It's pretty good. Is that if I were in this position and I were to do this, I can get over it, but I'll get over it that way, right? And so monkey see, monkey do. That's it. You should be able. Hopefully, you can do it properly. It's easier for you guys because there's a lot less to undo, right? But as you go up over it, most people start really good, and then in their brain they'll be like, I gotta get another 4 inches out of this. Well, there's 2. Now I can lift it up and I can step over. Pretty good, right? That's the number one compensation, is that people will turn that leg out and they'll turn their foot sideways. And so we just look at, the first thing you learn how to do is pick up those cheat moves, the most common cheat moves, and then you look for those first. If you don't see those, then you look at the rest of it.
What you look for, the bar stays parallel, the ASIs to stay parallel, the knee and ankle and hip are in alignment as they go over and come back, and their trunk is straight, so that's why you need all the views. This is the number one compensation that Dr. Sidney was talking about, where you start to see hip rotation, the knee and ankle now are no longer in alignment, or you see them flex the trunk when they go over it. So that would be a 2. This would be a 1. Inability to balance on one leg, and you're like, well, I can't do that. Well, realistically, you should be able to. Now, if I ask you to stand here for 5 minutes, we may start to see this, but you should be able to do this. Inline lunge. That's going to have to come down. No movement of the torso, feet in sagittal plane, knee touches behind the heel.
Okay, one more person come up. Then anybody will do.
Come
There you go.
on down.
Yeah, there you go.
You're the
I like
next
that.
contestant
Quick
on the
decision.
tricycle. Just sit down.
tibial tuberosity, I think.
To the,
And then her feet are that far apart, yeah. So just measure tibial too.
that's right.
Or actually, you might want to do it to the top of the knee. Yeah.
All right, go ahead and put your front foot here. So this is the advantage of, put your back over, back towards Dr. Sidney, face me. And put your right leg at the 0. Put your toe in spine. And put your other foot on the back behind 18. There you go.
So what we're trying to do is give her enough room
There you go.
that she can squat one knee in front of the other and not touch her knee to the back of her leg. That's all we're trying to do.
What you're going to do here is I want you to go down and lunge and touch down right behind your front leg and then come back up.
Okay, so let's scoot this leg back. There you go. Okay, good. Good. And so we could scoot her in, but that's pretty close. Let's go another 2 inches forward, right? This way. Perfect. Come back down. So you can make it up. That's what you have to do if you don't remember how to do it. When you do these as a fitness person, or generally you'll do 100 of them in a day. We don't use this screen a lot because we use the one that's for healthcare practitioners, but very good.
The other recommendation that they actually have
Thank you.
is to have the book out when you do this.
Yep.
So you have the pictures and you see the movements.
We have the cheat sheets out usually. Yeah.
So this would be a 3. This is typically a 2, which is where she was. The back knee slides off. They start to have trunk rotation or trunk flexion. And that's the whole point of the bar behind their back, to make sure that it's straight. And then 1, inability to squat down. Shoulder mobility. Don't come up here if you have shoulder pain. So is there a volunteer who does not have shoulder pain? So first thing we have to do is measure from the distal wrist crease to the tip of her fingers. So that gives us our measurement of what is one hand length, and that's kind of what we're looking at here. And so basically all she's going to do, go ahead and face the screen. So you can see this. Yeah, and bring your arms back. Make fists though.
Okay.
We really don't have to measure that.
Okay, now do it one more time. So we kind of do have to measure that, or at least we have to be paying attention. And the only reason I say that is that if we just look at the end result,
Because she worked.
you can get there, right? But if we look at how they get there, a lot of times they'll have to do this to get there, and that's a positive test. So, she's probably good. She looks pretty good doing that. But don't just look at the end result, look at how they got there. Yeah.
So one hand width or length, excuse me, is a 3. 1.5 is a 2, and then not within 1.5 is a 3. Doesn't matter how far apart they are. It's not like, or you're not a 1 minus or a 1 plus. You're a 1 or you're a 2. Understand that this is very common in your overhead athletes, that this will not be equal. Their dominant arm is usually lacking internal rotation, and it has increased external rotation. Whenever you do the shoulder, you also do the clearing test. The clearing test is simply put your hand across to the other shoulder, bring your elbow up to your nose, and that's to see if they have any pain. And the theory is if you're impinging tendons inside the GH joint, this will cause some type of pain.
And so can I use that pen or pencil? It's a pencil. It's got an eraser on it. It's got lead. Probably graphite. So with this test, what we'll do is we'll place this right on the front of their shoulder, and we'll place the heel of their hand on the front of their shoulder, and they'll lift up from there, right? Because this looks a lot different than that, right? So if we're trying to isolate the shoulder, heel of the hand stays on there, and then you lift. So mine's positive on my left shoulder, but I can make it negative by cheating. So that's why a pen or something is handy, just to keep that on there, and then you lift from there.
So if they get a 3 and then you do that and they have pain, they now go to a 0 and they get referred to a medical professional. active straight leg raise is done a little bit differently. They lay down across the board. The board goes directly under their knee, and then you're taking measurements as they do an active straight leg raise, basically from the ground to their heel. There's some debate on this one because they focus less on the angle of the knee. So most people that are in medical professional world say that your knee has to be perfectly straight when they do this, and they focus on that a bit less. They can't do this, but the idea is that they don't pick on that so much.
I mean, the further you bend your knee, the more your foot goes over the thing to start with, and so you'll see the hair.
So really what you're looking for is the vertical line of the malleoli resides mid-thigh. So basically if we take the malleoli and split them and come down, it's mid-thigh. So that's how we know that they have a 3. Because if they bend their knee, what happens to the malleoli? They move over here, they're not a 3 anyways. So we can go through that. A 2 basically means it is at the joint line, so they get to the knee. And then a 1 is below the joint line. So that's our cutoff. They can't lift up so that the ankle sits above the knee. It's a 1. They get to the knee, it's a 2. They get above the knee, it's a 3.
Yeah, so just make sure that you're watching to see, the first thing you might see is them roll a little bit. As soon as you see them start to roll, they fail. Or that's their
Or
ankle.
bending the other leg.
Yes.
So,
When they lift one leg, what should their other leg do? It should press down.
So once they run out of motion, then you'll see them lift up. Yeah.
So you should see the knee flatten out as they lift, and then the minute you see it lift off, it tells you they're trying to compensate the additional motion. Stop there. Trunk stability, we'll actually do this one since it actually requires some movement. But basically, trunk stability is a push-up. It's just done a bit differently. What we want to look for, body lifts is a unit, alignment of the spine, and location of the hands. This test is done differently for men and women. So who wants to be our volunteer for the guys? I'd ask you on the tables, I'm afraid of that.
Yeah.
That's not a statement about you in any way, shape, or form.
That's all right.
So go ahead and face me and get down to a push-up position. We want your thumbs aligned with the top of your head, so you don't want to bring your thumbs all the way up.
So most people say, well, I don't do a push-up like that. Well, we're trying to put you on the edge of what you should be able to do so that we can see if you're on the edge of dysfunction.
We want him to be parallel, but again, I'm not going to correct him. He's pretty close. So all I'm going to say is go ahead and go down as far as you can and then come back up. Go ahead and do it one more time. And come back up. Did we think he moved as a unit? Pretty well. Did he stay pretty parallel? Yeah. So that would be a 3. He agrees. He's the smartest one.
Most people won't, the majority of people, if they're really fit, they'll be able to do that, but, your average person will really struggle with that.
So what's the difference for our ladies? The ladies, instead of doing it with the thumb at the top of the forehead, they do it at their chin. So that's where they start. If they cannot do that push-up, meaning they physically can't do it, or they can't do it in alignment, you ask them to then change where they move. At this point in time, the guys go down to the chin, and the ladies move down to the clavicle, so across from their collarbone, basically at the top of their shoulder.
Okay, so let's redo that one more time. I want you to start in that down position. Because that's where we start. We actually start down on that one. So thumbs at the top of your head.
I was trying not to make him lay on the floor.
Yeah, well this will be interesting. Because this is
So back to thumbs up here.
engaging from the bottom.
Yeah.
Yeah, start completely flat. Yeah, non-weight bearing. And now lift from there. Fine.
Back down.
And this is a good abdominal test, core stability test.
I was trying to do that.
Because what you'll see a lot of times is as soon as they try to engage, you'll see the hips break. And remember what Shakira said.
Inability to do this, that modification gives them a at that point in time. This is our clearing test. Our clearing test, they lay flat on their stomach, They keep their hands, usually it's either at the shoulders or down below their waist. Typically most people start at the shoulders. And they just do a press up, keeping their hips on the floor. They don't have to keep it, so don't tell them to try, but the idea is they do a press up as close as they can naturally with their hips on the floor. And if this causes pain, they get a 0. Rotary stability. Basically, at this point in time, it's one of 2 motions. A score of 3 means that they can get in a quadruped position on their hands and knees. And with keeping their spine flat, level, they can take the same side back and do a unilateral one-sided crunch. Meaning they can take their right elbow to the right knee without moving, their left elbow to the left knee, and they don't fall over, they don't lose their balance. If they can't do the unilateral crunch, they go to a rotary, meaning they go to the opposite side, because that tends to be an easier movement pattern for people. So if they can do it unilaterally without falling over, perfectly straight, that's a 3. If they can't, you go to the rotary score. If they can do that under the same criteria, that's a 2. If they can't do that, then it becomes a 1. And I would love to demonstrate, but we're down to 1 minute.
How many do we have left?
That's the last one, minus the clearing test.
Okay, perfect. So the take-home message is that you can do the training online. You know, it does cost money, but if you're looking for wellness, think about things other than your basic fitness measures, because it'll never give you a very good measure of wellness. So, thank you.